Today we discuss stereotactic radiosurgery for brain metastasis. So it's really a very large topic, and I'm happy to have any questions at the end or following the lecture by any emails. I'll send you my email.
Yes.
Then we can, and I'm happy to do another part if needed. But let's start today and we'll see what's in there. So I have no disclosures. And as you know, brain metastasis consists of the most common intracranial tumors in the brain, more than the primary gliomas and lymphomas and primary brain tumors. And it's account about 20 to 40% of patients that develop brain metastasis. So now, why the incidence of brain metastasis increases, there's like more diagnostic workup improving and increased cancer prevalence for the patient, more potent systemic therapies that make the survival of the patients more, so we can see more. And also due to the better management approaches. So as you all know, lung primaries is the most common contributing to that brain mets in around 60% of cases, followed by breast and melanoma. So now, the best diagnostic tool to look at the brain metastasis is MRI brain. And we have many sequences that to look at in the MRI brain, but can anyone tell me which is the best to look at for brain metastasis?
T1 post-contrast?
Yes, and it should be thin cuts, right? Because if it's thick cuts, you can, like it's 2D, you cannot see the everything in the brain in detail. So you should have it in 3 millimeters minimally, so you can see every single detail in the brain. And also, so what do you see in the T1 pre-contrast? Like, so if it's helpful, or if it's helpful, what shall you see in the T1 pre?
Sorry, we didn't get you.
Can you repeat the question?
So T1 pre-contrast can it be helpful in any way?
It will just show us the edema and differentiate us if there is any midline shift or rough estimate of the size of the lesion, but no, it won't be very helpful in radiotherapy planning, I guess so.
Okay, so T1-3 actually you should not see anything from the brain metastasis unless it's hemorrhagic lesion. You can see maybe bloody, like bright things, but if it's not, you cannot see it. T1 post is the ideal. T2 for edema. So T2 is for showing edema, and there is something called weighted images in WI. So I can share with you these three consequences to kind of know how to look at the things with different sequences. So that's a patient that had a surgery for a brain metastasis. He underwent craniotomy for metastasis, and that's the surgical cavity here. And it is pushing a little bit in the midbrain. So when you look at the first picture in the left, the first image in the left, it shows T1 post contrast with enhancement, right? Can you see that enhancement? Can you see my pointer?
Yes, we can.
Okay. So now we want to know if that's a residual disease after the surgery or if it's like post-surgical changes, blood products, and that stuff. So what we do is we will pull the T1 pre-contrast and look at the same cuts. The T1 pre-contrast actually, if it's 10 cuts, that's the best. The one I've used here is a T1 pre-contrast thick cut, so it's not really aligned to the same cut as you can see, but can give you a rough idea about what's going on. So if you can see anything bright in T1 pre, so that means we are looking for blood products here. So if it's a bright without the contrast, then you're looking at the blood products and post-surgical changes. So that's more towards not a residual disease. To confirm that, you will put the sequence of SWI. So that's the SWI, the weighted images. And usually the blood showed itself in SWI with a black rim. Even if it's a bright in the middle, it's a black rim enhanced. So that confirms that what you're seeing is a blood product. So that's not a residual. So that's kind of like how to look at the sequences, the different sequences for the MRI for the brain metastasis. So as we said, what comes in a bright T1 high, like T1 post contrast, that could be bright the meds itself, anything takes the contrast, protein, hemoglobin, and melanin. All of those should be bright in T1 post-contrast, so we have to take care of like what we are looking to. Those are some types of primaries that present as hemorrhagic brain metastasis, like melanoma, brain metastasis, choriocarcinoma, renal cell carcinoma, thyroid cancers. They become as hemorrhagic brain metastasis most of the time, and so you can see those even in CT scan, right? That's the CT because it's a bright bony component. For the NCCN guidelines, we all know that the brain MRI in asymptomatic patients as a baseline workup, it's done for small cell lung cancer patients for stage 1 to 4 non-small cell lung cancer and stage 4 melanoma. So there are no evidence base to do brain MRI as baseline workup for patients with breast cancer, especially if they are asymptomatic and baseline. There are many studies that was done to consider that in doing brain MRI as baseline for breast cancer patients, but there is still no like evidence base, and it doesn't change the NCCN guidelines. But you can see some studies that recommends that even if the patient is asymptomatic, especially in HER2 positive patients that have a high risk of brain metastasis and triple negative. But those are the common to do brain MRI as a baseline. So when you look at the T1 post-contrast for those brain metastasis lesions, you have many differential, wide differential that maybe you think about it. So it's either brain metastasis, anaplastic astrocytoma, glioblastoma multiforme, lymphoma, and abscesses. So that table could summarize the biological features of each entity. So maybe it's helpful to really differentiate, but it's sometimes really hard. So if it's metastasis, as we said, it will be well circumscribed, contrast enhancing with maybe edema in T2. And the location of the brain metastasis usually, if you take care of this point, it's usually located in the gray-white matter junction. So it's just kind of like the common areas where the metastasis present. So if we're looking at high-grade gliomas, it's usually heterogeneous in contrast enhancement, and it has a very significant component in care and T2, and that's that we guided by to delineate our tumors, so we have to chase all the edema. Some institution doesn't do that, but here we chase the care and T2, so we make sure that everything is encompassed in our GT. And then the location of the high-grade glioma could be multifocal and may cross the midline, so it's not like specific location. For lymphomas, it's usually homogeneous enhancement, and it's usually periventricular in location, and it could be multifocal. And the abscesses, we all know, it's a ring-enhancing lesion. So that's kind of like helping in differentiating some of what you're seeing, but not really cut points off. So now, if we're talking about the treatment options for brain metastasis, so it could be starting from supportive care, not doing anything for the patient till we like to some of the medications on board, like corticosteroid, anti-epileptic drugs, polybrain radiation, SRS, surgical resection, systemic therapy. So all of these we will discuss in details going like later in the lecture. So one of the shared materials that I share with you is the QUADS study. So anybody can tell me about the QUADS study if anyone have the chance to read it and why it supports supportive care for some patients. Okay, no problem.
You can see we haven't.
I shared materials for you, but just to make sure that you have as much as you can. No worries to read it before the lecture, but I would like to have it going onward. So for the QUADS trial, what they do, they elected patients with old age, like above 60 or 70, and they were with poor performance status, and they studied those patients having whole brain radiation versus just supportive care. So what they end seeing that doing a supportive care for those categories of patients with poor performance status, old age, is better than doing whole brain radiation even. And that's better quality of life for them. So sometimes you would say, I will not radiate on that patient, especially if he's like old age, you will not give him more side effects with the whole brain radiation and more fatigue, more cognitive problems, and we will come to that in one of the case scenarios I have today. For the steroids, so a couple of years ago, that was a standard to prescribe steroids for every single patient having stereotactic radiation, at least the day of radiation to start takes or the day before, in a medium dose for short course. But now we are not prescribing that anymore unless the patients develop any symptoms the day of the radiation or after. And the same as for the anti-epileptic. So it was prophylactically prescribed for most of the patients, and now it's not. For the holy brain radiation, it was a historical approach to use, and now we are in the era to avoid holy brain and to spare the patients from having this modality of the treatment as much as we can, given the options of the surgeries and given the options of the focused radiation and the systemic treatment. So we'll talk also about those entities and details. So for the CNS ASCOS no joint recommendations, so there is the prophylactic anti-epileptic drugs are not recommended for routine use in patients with brain metastases who are otherwise seizure-free, unless the patients present with seizure, of course. And sometimes you feel like you want to prescribe this anti-epileptic medication to your patient prophylactically, especially for the lesions in the motor spectrum, or for those lesions that having a mass effect and significant edema with midline shift. So sometimes you feel like your patient is really at higher risk edge of having a seizure, so you may start them with anti-epileptic drugs. And we are, as a radiation oncologist, should not deal with that, but you will see, like, you will be the one who guides your patient for this. So usually what we prescribe is Keppra, which is the anti-seizing medication used for this, and it's 500 milligrams twice a day. This is the dose that you start with. So unless the patient's seizures is not controlled, you can push up to 750 milligrams twice a day or up to 1,000. But at some point you have to involve your medical neuro-oncologist on board. And what is done here, if the patient started on Keppra, let's say for any reason, he was symptomatic, prophylactic, whatever. So what we usually do is we keep the patient on Keppra as far as he can tolerate that. So if it's not affecting his, not contributing more with his fatigue and he can tolerate this medication, just keep your patient on it, the 500 milligrams twice a day. All the patients going to surgery to do craniotomy, they put them on anti-seizing medication for the week of surgery, and then they taper it down because the mass effect is released by the surgery, so you can exempt your patient from having that. For the steroids, again, also it's not prescribed as routinely as before. It's just if your patient is symptomatic. Be careful how to prescribe steroids. You should start with like 4 milligrams a day to twice a day. So 4 milligrams a day to twice a day. And maybe you need to push to 3 times a day sometimes. And you have to make sure not to stop your patient abruptly from having the steroid. So he has to taper down gradually. So every 3 to 4 days, you should omit like 2 milligrams. So what I do, like if I start 4 milligrams by 2 for 3 days, then I start to do 2 milligrams by 2 for another 3 days, and then 2 milligrams by 1 for another 3 days, and maybe then stop, or having 1 milligram by 1 for 3 days and then stop. The idea of that is to taper it slowly and gradually. So there is insufficient evidence to comment on use of steroids for asymptomatic brain mets without mass effect. But again, there is nothing wrong. But this is what we are usually doing nowadays. Now, the surgical resection is one of the options that we can have it on board for brain metastasis. And can anybody tell me when you will be eager to send your patient to surgery for a brain metastasis?
When there is solitary focus of metastasis, there are no metastasis anywhere else, systemic disease is under control.
Mm-hmm. Yeah. Yeah. So whenever you're dealing with a patient with brain metastasis only, which is a single site of metastasis, or we call it, if it's one lesion only, solitary brain metastasis. So that's the best patient to go for surgery, because the thing that really threatening his life is the brain, nothing else. And he's well controlled extracranially, like young age, good performance status, so that's the best option to have a surgery. And that showed also overall survival benefits with the studies that we will discuss down the road. So, and usually you need surgery sometimes to prove what you're dealing with, because if the patient is still under like investigations of the primary tumor and he's still, you don't know if they were dealing with primary lung cancer, breast, whatever, like unknown primary. They need confirmation for that, especially if you're suspicious between metastasis, lymphoma, gliomas. So histologic confirmation is one of the indications. Also, if there is a large metastasis in the posterior fossa or having compression effect, you need to do that for mass release effect. If the brain metastasis having a hemorrhagic metastasis or as we said, single metastasis with controlled NDD in the body good performance status. So there are many factors contributing to your treatment decision when you're dealing with patients with a brain metastasis, and primary histology is one of the most important factors for that, because like for example, if you're dealing with a patient with a small cell lung cancer in the clinic and he presented with a brain metastasis, you will never ever do stereotactic radiation for that patient, and same set for lymphoma and germinoma. So those are kind of small cell type of tumors around the blue cells that metastasize like really aggressively, and they do not usually come in few numbers to do stereotactic radiosurgery. And even if the patient presents with 1 to 3 metastases, it's not an option to give focused radiation for a patient with small cell lung cancer. And that's because of 2 reasons. The first one is none of the studies discussing the brain metastasis approaches enrolled patients with small cell lung cancer, so we don't have a very, evidence base to do focused radiation for small cell lung cancer. And the other thing is the microscopic metastasis in the pockets elsewhere in the brain is very highly likely, so you're not controlling this disease with focused radiation with the actual ones you're seeing now, because controlling elsewhere gonna be like nothing, 0. The third point is when they studied the contaminated area around the brain metastasis coming from small cell lung cancer, the contaminated area for brain metastasis from small cell lung cancer was around 2 centimeters from the lesion. So if you have the lesion here, you have 2 centimeters all around in the 3D dimension that's contaminated with the tumor microscopically. So you cannot really control that with focused radiation. Compared to other primaries like non-small cell lung cancer, breast cancer primaries with the brain mets, the contaminated area is not exceeding more than 1 to 2 millimeters. That's why our PTP is just 1 to 2 millimeters, because you are already safe in controlling the disease microscopically. So in small cell lung cancer, you cannot control that. Regarding the number and size of brain metastasis, so there were many studies that started with 1 to 3 brain metastases and then discussed 4 brain metastases with IOMA trial and then 10 brain metastases in Yamamoto trials. But it's really still, we don't know what the cut point off would be, but at least I can tell you here in Brigham we do up to 6 for focused radiation, and then anything beyond that we enroll the patient based on a trial to do whole brain radiation, avoiding the hippocampal area versus SRS for every single lesion. So I mean, like, maybe you have your cut point off. I don't know, you're starting to do that. You have a cut point off for the numbers or not yet?
We haven't started doing it, but we've got a lot of patients presenting with leukometastatic disease to brain, and we have small cell lung cancer, breast cancer, but we haven't started doing SBRT yet.
Yeah, so I mean here we're following the 6 as the 6th lesion as a cut point off, and beyond 6 we will not use focused radiation. And actually what really matters is not the number of metastases, it's the volume of metastasis. So if I go to the next slide, here are some trials that discuss the overall survival related to the volume of metastasis, not the number of metastases. So as you can see, the volume of metastasis is really significantly associated with worse survival if it's the volume like more, but not with the number of metastases. So you can see here this patient's first on the left having multiple mets, but the total volume is 5 cc. Whether the second patient's having only 2 metastases, but the total volume is 8.4 cc. So it's not actually the number, it's actually the volume you're dealing with for radiating those lesions in the brain. And also from the factors that affecting your decision is presence or absence of neurological symptoms. So the best to do for your patients is not to radiate and to declare radiation. So if you're dealing with a patient with very tiny lesions, limited number of lesions, he is recently diagnosed with non-small cell lung cancer, breast cancer, whatever, the best thing is to discuss with the medical oncologist to be on board for any systemic options he could be on that take care of the brain metastasis and to spare him from radiation. So I would say the best radiation oncologist who can say no at some times, like not to radiate, because we all know how to radiate, but we have to know when to say no and when to spare your patients from the toxicity. Disease status, as we discussed, like if your patient has an ED in the body, the brain is the only side, so you have to be aggressive with surgery and focused radiation. But if like the body is a mess, so it's not worth to do like focused radiation or even maybe whole brain to find him more side effects. So plans for an ability to tolerate surgery and systemic treatment, as we said, so all on board, and the overall prognosis. So now, historically, the approach was for brain metastasis doing whole brain radiation, but after SRS was discovered by the Sweden neurosurgeon, whose name is Lars Lexell, so everything was deviated to do focused radiation to spare the normal brain tissue from being exposed to radiation. And there are many indices for approving the plans of stereotactic radiation that named after his name. So you can see this name like Lexell Index, Lexell whatever, so you can know from where that name comes. And so all your course that you're discussing, stereotactic radiation and any site in the body, the main goal of that is to deposit a high dose which define target lesion and to reduce the dose to the surrounding tissue with the use of a steep dose gradient. So that's the main goal of doing the focused radiation, which is called the stereotactic. So now, let's see what does the SRS add to whole brain. So the first trial that discussed this question is the RTOG 9508 study. And this study enrolled patients with 1 to 3 brain metastasis, and they divided the patients into whole brain radiation only versus whole brain adding SRS after that. So in this trial, actually, it showed no survival benefit from adding the focused radiation to those patients after whole brain, but the subcategories of patients that having overall survival benefits were those patients having a solitary brain met, single brain met. So you can see the curve at the left showed no overall survival benefit in general for the whole patients, and the p-value was not significant. But when we are dealing with patients with single metastasis, so there were a significant difference in overall survival benefits for those patients having focused radiation after whole brain. And there is another randomized trial, which is the PATCHEL-1 trial. The PATCHEL-1 trial discussed the benefit of surgery in those patients with oligometastasis and adding whole brain radiation after that or just observation. And actually, the surgery was having also overall survival benefits in those patients. So we have to take care of, like, PATCHEL-1 studied the benefit of the surgery, but PATCHEL-2 studied the benefit of the adding radiation. So when we are questioning adding radiation, it will not show overall survival benefit, but when we are questioning the benefit of surgery, it shows an overall survival benefit. And we discussed PATCHEL-2 also in a couple. So in that, and also with this PATCHEL-1 study, it showed also, as we said, overall survival benefit for those patients underwent surgery with radiation, not surgery alone. And it showed also that the recurrence rate or the time to recurrence was really later on with the patients underwent surgery and radiation compared to patients underwent radiation only, which have earlier recurrence in the brain. So from that, we can say, like, every patient having a solitary brain met, it's worth to discuss with him having a surgery as an aggressive treatment to start with, followed by radiation, having the benefit of overall survival. So now, since SRS did not add in general an overall survival benefit, so the question, can we avoid whole brain for patients with 1 to 3 brain metastasis? So now, what's the benefit of whole brain, and how can we say, no, we don't want to do whole brain? actually all of the studies that address this question, we have the PATCHEL 2 study, the Japanese, the MD Anderson Chang trial, ERTC trial, and the Alliance trial. All those trials having the whole brain radiation added to the arm of surgery or focused radiation to address this question. So as you can see, there is no overall survival difference in any of these trials adding the whole brain radiation to those patients, but it actually showed a lower recurrence rate and better local control in the brain elsewhere, which we cannot achieve by focused radiation. So doing the whole brain is really better local control, but keeping in mind that you will have a neurocognitive decline in patients. So there is, it will be associated with worse neurocognition. That's why everybody just started to think about 58 patients from doing whole brain radiation because of neurocognitive function. So there was studies that discussed doing a whole brain, avoiding the hippocampus area, because the hippocampus area is the area of the memory function reservation. So in those studies, they were prescribing a dose of 30 gray and 10 to the whole brain, and we will delineate the hippocampus area, and then the metrics, and then when you delineate the hippocampus area, you will add 5 millimeter margin to that. So it would be this thing that I will show you quickly. So, William, are you on board?
Yes.
Yes, I am.
I'm asking. So I want to pull I want to pull the hippocampal contouring atlas. Can you share that with us? Because I cannot.
Yes, one moment, please.
Okay, I can proceed till you're ready. So what they do is these studies, they contouring the hippocampal area and adding 5 millimeter to that. And the metrics when used to approve those plans is not to have a max point of 16 gray in the hippocampus, and the mean dose would be less than 9 gray. And actually to avoid hotspots in any organs at risk, like optic nerves, brainstem, and those stuff. So doing that, you should do your plan with 3D or VMAT. So you cannot achieve those metrics with 3D, so you have to do this whole brain technique with VMAT to kind of meeting those metrics to the hippocampus area. There is a point to highlight on. So whenever you want to approve a plan for whole brain radiation, try to avoid having a maximum dose of 37.5. Try to have it as maximum 35, 34, because it's really make a big difference in cognitive function the patients have after whole brain if you approve with a max dose of 37.5 versus like 34 or 35. So it's one of the important things to look at when you approve a patient for whole brain radiation.
Sorry, Luda, I have a question.
Yes?
What was the dose of radiotherapy in the whole brain radiotherapy? Because if you are not giving beyond 20 gray, how can you give 37 gray to the eyes then?
So it's valid. All the whole brain radiation dose is valid, but because those studies rely on 30 gray and 10, so I would say if you're doing hippocampal sparing, just stick with the 30 gray and 10 because those metrics are related to that prescribed dose in those studies, which is 30 gray and 10. But you can do whatever if you're not doing hippocampal sparing. You can do 37 and 15, you can do 20 and 5. So yeah. So William, shall we proceed or what?
Yep, I have it up. I'll switch to myself right now.
Okay.
All right, there we go.
So, yeah, thank you. So that's the hippocampal contouring atlas from the RTOG. So I would just discuss with you very quickly. So can you proceed on because I cannot control? Yeah. So to the slides of delineation. Go ahead. Okay, go ahead. Okay. So okay. So once we start to look at the hippocampus, start to look at the beginning of the ventricles and the temporal horn, and what you will delineate is the gray matter medially to that, and not go anteriorly beyond the ventricle. Do not go anterior or in front to the ventricle. Just the area of the gray matter hugging the ventricle medially. So if we go slowly, cut by cut, so that's the gray matter you would contour, yes. And then, yes, please. Okay, and that's the gray matter also, yeah. So you just will chase the gray matter medially hugging the ventricles till you reach the end of the ventricle. So that's really easy to guide you. So the ventricle will guide you. So we can go more down. As you can see, the gray matter hugging the ventricle. Again, yeah, perfect. So we can go ahead till the end. Yes. So whenever you still can see the ventricle, you should delineate the hippocampus. Yes, so there is still ventricle there. There is still ventricle there. That's the ventricle horn also, if you can see it here. Okay. That's still the ventricle we can see, so we're delineating the gray matter hugging the ventricle, okay. That's also. Perfect. I think you should still contouring here because there is a ventricle there, still there. So that's a kind of rough idea how to contour the hippocampus area. And then you will add to that 5 millimeter, and then you will meet your metrics that we discussed on the other slides. Thank you, William. Oh, that's the kind of like how do you look at it sagittally and coronally. So the red one is the hippocampal, and this the 5 millimeter expansion around it. Okay, perfect. So we can go back to the slide.
Sure thing.
Okay, perfect. Okay. So for simulation, we all know in stereotactic radiosurgery, the best important part is the immobilization part of the patient and fixation of the patient. There are many masks that could come from different companies with different setup errors. The one we use here in Brigham is called the Q-Fix Encompass mask, which comes in double layered in the chin. So it becomes like long, and they fold it on the chin, so it becomes double layered with the chin area. And then we've used the thin cuts T1 post contrast, which is called infrared or T1 post contrast. It comes in 1.5 to 3 millimeter to guide you delineate your target. So those are different types of masks that you could, I don't know what you will have in the future when you're having this focused radiation, but I want to highlight on some points. So first, if we start from down going upward, so that's the thermoplastic mask with Vital block. It has a setup error of 2.2 millimeters. Okay, so when they add the when they bring or they discover like the dedicated thermoplastic mask, which is the Brain Lab mask, it comes with setup error of 1.7 millimeter. And then if you're using the Vital block with this mask, it lessens the setup error to 1.16. So the Vital block could help you in fixation the head of the patient, especially in the XYZ dimensions. Now, the most important thing was adding the cone beam CT as a way to like make sure that the patient is not immobilized. So that makes the setup error even very, very low. It reaches up to 0.9 millimeter. And with the same thing, with Vital block having the cone beam CT, we are now reaching a setup error of less than 0.5 millimeter plus minus 0.7. So what I'm trying to say, it really depends on what type of mask you're using, the accessories you're using, and cone beam CT, which is the image guided, is the most important part to make sure that you're treating the right area. For the prescription doses, we have the RTOG9005. In that trial, they kind of like having a prescription of different doses, depends on the size of the lesion. So what they end up doing is prescribing 24 gray for any lesion up to 2 centimeters, and then 18 gray for any lesion between 2 to 3, and then anything beyond 3 centimeters, they were prescribing 15 gray. And I would say if you can, like any lesion that becomes beyond 3, it's considered a little bit large lesion. So if you can just fractionate, like doing as a stereotactic baby therapy, SRT, that's better off prescribing 15 gray in 1, because the local control is really better when you fractionate for big lesions. And you should prescribe a dose of 30 gray in 5 for intact lesions, not 25 in 5 like the post-operative cavity radiation SRT. So if you're radiating a cavity, you will prescribe 25 in 5 because you should have a gentle dose for normal brain tissue. But if it's a big intact lesion, you will prescribe 30 gray in 5. So that's kind of a trial that may guide you to how to prescribe the doses. Depends on the size of the lesion. In a program, we prescribe 20 gray and 1 for the 1 fraction whenever we can meet the metrics. But other than that, we will fractionate or going maybe to 18 gray, but not to 15. 15 is not really good for local control. Those are the trials that were addressed the question of having post-op radiation SRT for cavities after brain metastatectomy. So that was a study run by Mahajan et al. And it showed better local control for radiating the cavity post-op versus observation only. But if you can look at the results really well in the paragraph of findings, you can see that there was a local recurrence of 43% in the observation arm and versus 72% in the SRS group. And if you take the ratio of 72 over 43%, it's kind of like 50% local control and 50% recurrence. So it's just really the benefit of like the half benefit of that. So it's better local control, but it's like 50% local control versus 50% recurrence. So what I'm trying to say is there is a debate point on that, like whether you need to radiate the cavity or not. So you can do it, you can just observe. Like here in Brigham, we do post-op cavity radiation, but like in Mass General, they don't. They just observe and they just keep it whenever needed if there is any recurrence. So that's the curve that showed better control with post-op cavity radiation with SRT, but it doesn't show any overall survival benefit or any control benefit elsewhere in the brain because you're just controlling the area of the cavity. So in my opinion, I would recommend doing focused radiation for the cavities. First, because the first treatment for the patient is the best, like better than the salvage, because you cannot expect what you will have if there is any recurrence. And actually, the second point, the risk of seeding after surgery is really high, and it comes in the dural attachment, not on the brain parenchyma. So it will be kind of like difficult to chase that recurrence if it happens. So nowadays, because of maybe the irrigation in the surgical ward or whatever, there is a very high risk of like dural seeding after surgery. So I would recommend doing radiation. And actually, you are prescribing 25 gray in 5. So it's not harming your patient. It's just controlling the disease because it's a gentle dose for the brain tissue, right? So I would say maybe doing the post-op cavity radiation is better than observing. But there's nothing wrong. You can just observe, and whenever the patient had a recurrence, you can radiate. But you have to discuss with the surgeon first. Maybe he has to get in back again, resect the recurrent area, and then you would radiate. Because as you know, the radiation is really highly effective when you're dealing with microscopic disease rather than intact disease. But if the scenario comes like he cannot resect that area, that's a different scenario. So just kind of like how to think about those situations if you want to observe. And usually we do fractionated stereotactic radiation for cavities, keeping in mind that we are radiating normal tissue. There is no tumor in that situation, so you would have to be gentle. So fractionated radiation is gentler than doing one, because there are many studies that discuss doing SRS for post-op cavity, which I do not recommend. Just do fractionated radiation to be gentler for the normal brain tissue for the protection. Okay, now for the contours. So your GTV is guided by the T1 post-contrast enhanced part. And actually, I would recommend you to zoom in when you're delineating those lesions. Just zoom in, make it bigger, and try to chase the contrast enhanced area as much as you can. Even if you see it like hazy in the borders, chase the hazy enhancement better than having underestimating of the lesion, because the recurrence then would be very difficult to deal with, and you cannot do focused radiation after focused radiation. There are many studies that may allow this, but here in Brigham we don't do SRS after SRS. So the best treatment chance for the patient is the first treatment, so you have to trace the C1 enhanced part very carefully. And I would recommend you also to look at the axial component of the MRI matched with the coronal and the sagittal cuts. So whenever you're contouring a lesion, try to look at the axial, the sagittal, and the coronal cuts. Because most of the time, like I usually started to delineate on axial, but when you look at the sagittal, you would not believe you have a mess from enhanced part that you're not seeing on axial at all. You feel like you're really very doing great job, but then when you look at the sagittal part, you would see a mess. So just make sure that you're looking at the all axial, the axial and sagittal coronal. Then the PTV margin recommendation is 1 millimeter for any intact lesion and 2 millimeter for cavity SRT. That could be, it's not like this is the way we're doing. You could have 1 to 2 millimeters for intact lesions and maybe more for the cavity radiation. And that really depends on how the QA done, how the immobilization, the mask you're using, those setup things that we were discussing before. So your PTV margin is really depends on the institutional QA things and setup settings. So as stated by ACR and ASTRO guidelines, targeting accuracy to intracranial metastasis of approximately 1 millimeter must be aimed as the infiltration zone of the brain metastasis is usually small and to recent toxicity. So if you remember when we were discussing the contamination zone around the intact enhanced lesion in a brain metastasis from lung, breast, and those primary, they were not going beyond 1 to 2 millimeters. So you are very good in covering 1 millimeter PTV. So that's the meaning of that statement. And then the question is how close to planning day your MRI is acceptable. So meaning like which MRI you can rely on delineating your target and say, hey, I would rely on this MRI dated whatever for delineation my target. There is no right answer, but here in Brigham, what we do is, if the MRI is within 14 days from the scan to the start day of treatment, you're good. You're good. But if it's beyond the 14 days, you have to have a new MRI for that patient. Does that make sense? So it counts from the day of scan till the start date. So if you are within 14 days till the start date of the beam on, you're good in having this MRI as guidance for your GTV. But if you will exceed the 14 days, so the best thing is to have your MRI within 14 days of the starting date of treatment, okay? Now for the daily setup, when the patient is ready to have the treatment today, you will check the immobilization before the beam on with exact track and com beam CT. I would say the com beam CT have no cut points deviation. Like I would say, if you see 3 millimeter deviation, don't accept the image and try to repeat it, try to adjust the patients. No, it's just kind of, how do you check the fusion? When you fuse the MRI with the CT planning, it's the same for the com beam CT. So whenever you are on the linear and the therapist call you to approve the immobilization of two patients, you're looking at com beam CT in the axial, coronal, sagittal. You will look at it in the bone window, in the soft tissue window. What you're looking at, you're trying to match the sulci and gyri of the brain, the ventricles, the brainstem location. Do not look at the skull. Don't worry about the skull and the bone. The bone is like the outline and just should not be tilted for sure, but at least you have to be more careful for the soft tissue component inside the interested area you're treating. If you're treating many lesions, then you have to be careful that you have a global fusion or a global com beam CT that is accepted to treat your patient. So it's anatomical check. For the exact track, there are many, like it depends on the company you will working with, but for the exact track, like here in Brigham, for the SRS, we accept up to 0.7 millimeter in the XYZ deviation. Sorry. And 0.7 degrees rotational and yaw pitch. But for SRT, we are accepting up to 1.25 millimeter because the cavity is really irregular and it shrinks with time. It's having like many anatomical variations, so you accept up to 1.25 millimeter in coordinates and 1.5 degree in rotational. So if anybody asks me about rotational, this is the rotational, what I meant by yaw, pitch, and roll. So in the x-axis, you have the rotational roll, and in the y-axis, you have something called yaw, which is the degree of rotation, but in the y-axis. And in the z-axis, you have something called pitch rotation. So those what meant by the rotational degrees. So that's kind of like how do you accept your patient's immobilization the day of treatment. And for sure, if you cannot meet this, like you feel like your combing CT is really in mess and the exact track is cannot catching the maximum points you are heading to, you can just say, maybe we need to do, like the therapist first start to position the head of the patient in certain ways. But if that's not helpful, maybe you need to do resem and replan, right? Because you cannot treat with deviated combing. So now, going to the planning, you will prescribe on linear-based SRS to 80 to 90% isodose line. But if you're doing gamma knife, it's going to be prescription to the 50% isodose line. So you cannot imagine if you're prescribing in gamma knife 20 gray in one for that lesion, you will have in the middle of the lesion hotspot of 40 gray. So it's really heterogeneous, heterogeneous plan with very high hotspots in the middle compared to the linear base. And usually the energy we're using for treating brain metastasis is around 6 MP. You can use 10 MP, but you're good with the 6 MP. So now how do you judge your plan? How do you approve your plan? So you will look at the GTV coverage and activate the isodose lines for the GTV coverage. So what we're using here is you should have 100% coverage of your prescribed dose to the GTV. So if you're prescribing 20 gray, this 20 gray should cover the whole GTV 100%. For the PTV coverage, it should be 99%. You can relax it and make it more relaxed, like some institutions approve up to 85% PTV, but I'm kind of like telling you what we're doing. So we're approving a PTV of 99%. For the V12, it's not, so for the V12, it's not that the right volume you should track to approve your plan, but this is kind of like most literatures and the studies rely on this volume to approve the brain metastasis coverage. And I will discuss this with detail. So first, why we would rely on V12. So if you can look at this slide is a study done by Koritko in 2006, and it showed the rate of radiation necrosis depends on the volume exposed to specific radiation doses. Okay, so if you look at this line, the V12 gray, so you can see this kind of the cut point of having low radiation necrosis versus a very high probability of radiation necrosis beyond this metric. Okay, so that's why most of the institutions having the V12 as a kind of the volume that we will approve our plan of brain metastasis upon that metric. So what does that mean? V12 should be less than 10 cc, meaning that the area that receives 12 gray from your dose prescribed of the normal tissue of the brain should not exceed 10 cc. So I will repeat it again. You have a brain metastasis here, and you're prescribing 20 gray. And then you will look at the isodose line of the 12 gray, which will be the circle bigger to that, okay? So you will look at the volume of the normal brain tissue that received this 12 gray. So what you will do, you will subtract your GTP from that, And if there is any bony component, you will subtract that. So you're looking at the normal brain tissue volume that received this 12K. So you're good if that volume is less than 10 cc for the radiation necrosis probability. If it's higher than that, so what you will do is either to prescribe lower dose, so you will go to 18 gray, for example, or to fluctuate your radiation dose, so you will do SRT instead of SRS. Any question about this? Okay, perfect. So for the organs at risk, I will show you the metrics allowed now. And for the confirmability, there are indices that were there to approve your plan. There is something called conformability index. This conformability index is equal to the volume of the treated radiation dose volume, which is your GTP or your PTV, the volume you're treating, divided by the PTV volume. So it's logic to be 1, so the ideal is to be 1. But in radiation planning, you will not achieve 1. So it's acceptable less than 2. And you will not have any problems having that with VMAT era now. I would recommend you to have this calculation for each plan when you first start. But then if you just see like everything is going in the right way and you will not have any problems with the conformity index, just ignore it. This is really important more in the gamma knife based stereotactic radiation, not with the linear VMAT based radiation. But I would recommend do it first to just kind of the QA of your plan. There is also another index called the gradient index. That index is really assessing the steep dose fall off of your plan. So imagine you're having, you want to do a very steep dose fall off for your prescribing dose. So it's going to be very hot. You will have a very hot spots in there. So imagine like it's a triangle with either a high peak or a lower peak. So if you want to have a very high steep dose fall off, you will you will have a very high hot spots in the middle. But if you will relax your PTV steep dose fall off, so you will have less hot spots in the middle. Okay. So it depends if your priority is to protect the organs at risk, so you're okay with the hot spots, or you just have some space to cover, so you will take care of the hot spots not to exceed 150% or 140% for the stereotactic radiation. Okay. If you're doing cavity radiation, make sure hot spots do not exceed more than 115 to 20% of the prescribed dose, because again, you are radiating normal tissue. You are not radiating a tumor. So that's the heterogeneity and hotspots we're talking about, the dose fall off. You have to also activate your low dose and try and look at the low dose to the brain, the 3 gray and the 5 gray, and how it covers the brain and how much of the brain covered by this low dose. It's important to look at it. And if you're treating multiple meds, so I will discuss this with the different isocenters. We're going to that in a few seconds. And prior SRS, as I said, you cannot treat SRS after SRS for the same lesion. So if your lesion is progressing after focused radiation, it's not an option to have another focused radiation again. There are some studies that would say it's fine after like 6 months or 1 year interval. So it's a matter of regulation between the 2 radiation courses. But here in Brigham, we don't do that ever, never. And maybe one of the options to like send your patient to surgery to resect that progressing lesion, but not to irradiate again. But you can do focused radiation after whole brain. So if the patient received whole brain before and have now brain metastasis, you can do SRS, because whole brain is not a risk of radiation necrosis probability. Okay? So that's the discussion of V12. Now, to kind of having a very dose fall off and to protect the organs at rest around the lesion, we have the choice in VMAT to have the non-coplanar fields, meaning you can pick the couch. So when you can pick the couch, so you will have beam from different arcs, from different angles. In that way, you will concentrate your dose on the brain metastasis, avoiding the organs at rest from different angles. So the choice of non-coplanar fields. So if you hear about the non-coplanar fields, meaning you have couch take while you're having your fields for the planning. Usually, we need to have 4 to 6 partial arcs in planning. So the physicist needs needs 4 to 6 arcs to cover our dose. And VMAT is very great option to spare the organs at risk, and it's really quicker than IMRT, okay? So now dose metrics for the organs at risk. So if you are prescribing stereotactic radiotherapy for a cavity, so the brainstem metrics would be 25 gray, chiasm 25 gray, and optic nerves 25 gray max. For the SRS prescription, you will not exceed 12 gray to the brainstem, chiasm 80 gray, optic nerves 80 gray, and also, as I said, the V12 should be less than 10 cc for that lesion to avoid radiation necrosis. Now, for the point of normal tissues minus GTPs would be less than 5 gray. This is what is called integral brain radiation dose from this plan you're prescribing to your patients. So if you're prescribing brain metastasis radiation for 5 lesions, so you should having an equation of having the normal tissue of the brain, so you would delineate the brain and then subtract all the GTV's volume. So GTV 1 to 5, okay? So when you subtract those, you would look at the normal tissue of the brain and how much dose it will receive from this specific plan, that specific day. And that should be less than 5 gray. If you cannot meet that metric in less than 5 gray, so you should treat your lesions in 2 separate days, not in 1 day. So that's very important in patients having multiple brain metastases.
Sorry, can I interrupt you for a question?
Yeah.
Hello?
Yes, I'm hearing you.
Yeah. So when we exclude the GTV from the normal tissue, what about brainstem and all the other thalami? Do we exclude them from the from the normal tissue as well?
So no, just to avoid the GTVs, you just subtract the GTVs where the tumor is, the volume of the GTVs, not the brainstem. The brainstem is a normal brain tissue.
So brainstem will be a part of the normal tissue.
Yeah, yeah. So as you are delineating for whole brain, right? When you're delineating whole brain, so the brainstem is from the whole brain, right? It's inside it, right? So it's a normal brain tissue. So what you do is you take the volumes of the whole brain delineation, you subtract the volumes of the GTVs, the whole GTVs together. Like let's say that GTV is 10 cc and that one is 3 cc and that one is 5 cc. So then you, when you subtract your GTVs from the normal brain tissue, you would say this volume, how many grays it received that day from the plan. If it's more than 5 grays, so you cannot treat those lesions on the same day. You have to split those lesions in 2 days.
Okay, and the other thing is when we talk about brainstem dose of 12 gray, is it the dose to PRV or is it the dose to brainstem?
It's dose of to what? Sorry.
So normally we draw PRV for the brainstem, PRV for the chiasm. Is this constrained for the chiasm or PRV chiasm or brainstem PRV? So basically I wanted to ask, is this constrained with or without PRV?
No PRV. That's a good question. No PRV. It's just the organ itself. No okay. PRV. Because if you will consider PRV, then your dose will be very high to consider this, right? Because then you will consider your brainstem is bigger, so you're fine to have. No, it's not. It's without PRV. Okay.
Okay. And just yes, just one other question. I was just asking this question to my physicist as well. To give the high dose in the center of the volume, do we draw a dummy structure and give a constraint, high dose constraint to that dummy structure, or it's just we give non-coplanar beams and just concentrate and make sure that the high dose area is in the middle of the field? So what would be the best way to bring the hot area in the center of the field?
So the maximum approved for the hotspots in the SRS plan is up to 140%, not more than that. 140% of the prescribed dose.
Yes, but how do we do that? Because
so yeah, so I think you're right. So I think roughly speaking, you will use 4 to 6 beam like arcs for each lesion. And with one isocenter or different isocenters, it depends on on how can you chase those lesions or not. But actually, if you're asking really pure physicist plan, I would recommend to have your physicists have a chat with our physicists of doing 1 or 2 plans at least, because this is what I did since I arrived here. Because I need to know how the physicists work on the plans to achieve our metrics that we need. Okay, so it's hard for us to tell the physicists what to do, but I think it's easier for the physicists to have this kind of teaching 1 or 2 plans to be, presented.
Yeah, and we do also see a lot of pituitary tumors. Would you recommend the same single dose and 2 to 4 centimeter dose fractionation for the pituitary tumors as well, or would you use a different fractionation for pituitary tumors?
You mean pituitary metastasis?
Pituitary adenomas.
So that's different. For pituitary adenomas, the short answer is try to do conventional, which is the 1.8 to 2 gray per fractions. That's the best. Avoid focused radiation unless needed, but that's different topic totally. We can talk about this in more details, but like short answer, try to do it as conventional. Like in meningioma, I would not recommend focused radiation. Even if the studies showed like benefit and the same local control for the conventional, I would say just stick with the conventional, which is the 1.8 to 2 gray, the long course.
Yeah, thank you. You're
welcome. So that's the first case that we want to just kind of think about it. So if you have that patient with a pontine metastatic brain stem, pontine brain metastasis lesion, okay? So now we want to prescribe, so I think if anybody can let me know how would we think about this case and what's the dose would be prescribed to this case, and with the material I shared with you for the brainstem radiation, if anybody can comment on that.
So it's less than 2 centimeter, but it's in the brain stem. So we can give 24 gray in 1 fraction, but then I think the constraint for the brain stem was around 25 gray.
So it's 25 if you're doing SRT, but if you're doing SRT, is it 12 gray?
Okay. Yes.
Actually, I want to correct this. So this should be the 0.035 cc receiving 12 gray. It's not the whole brainstem. It's the those 0.0. I will correct this and send it back. So, okay. So if you're prescribing 24 gray in 1, it's really high, right? Depends on the prescription.
Yes. Prescription of GTV to 100%. And PTV to 99% or 95%?
So
you said 85%, I think.
So the GTV should be covered with 100% of the prescribed dose. So that, like, let's say 20 gray. So you should cover this GTV with 20 gray. The PTV is 99%. But okay, so if I want to think about this situation, so I can prescribe 1 fraction for that patient. But I would tell my physicist the following. So I want to prescribe 20 gray to start with, and if you can meet the metrics for that, for the brainstem and the B12 metric less than 10 cc, so I'm happy to proceed with 20 gray in 1, especially in those lesions less than 1 cc. So there is a Jeremy et al. Study that I shared with you. So if you have a brainstem lesions with very small volume, you can go ahead and do 1 fraction. There is another Francis trial that showed if you, so that's the Jeremy trial. So it showed that for the tumor volume revealed, the volume of greater than 1 cc, do not do 1 single fraction. You have to either lower the dose to 18 gray by 1 or to do fractionation, okay? But if you have a lesion less than 1 cc, so you can meet the metrics, so you can go ahead and treat with 1 fraction. There is another French trial that was published, and it showed that lower doses in the brainstem metastasis can achieve the same local control and survival rates in brain metastasis elsewhere with minimal side effects. Meaning, if we are usually prescribing 20 gray in 1 for any site of brain metastasis, so if you're dealing with the brainstem metastasis, you can prescribe 18 gray in 1 instead of 20 gray in 1 for 15 gray in 1, okay? So just make it lower dose with better toxicity profile, okay? So, and you have to keep in mind that the local control of the marginal dose of 25 gray to that lesion, it gives you a local control of 85%. But if you go down to 18 gray, the local control would be 50%. And if you go lower to 15 gray, it would be 45%. So why I'm just showing you this? I'm showing you this to say, if you cannot prescribe one single lesion in one fraction in 20 gray for a brain stem metastasis lesion because it's a very high volume or you cannot meet your metrics, go ahead and do fractionated SRT. Do not do single fraction. Do fractionated. So what we do here in Brigham, mostly, and short answer for a brain stem metastasis, we do fractionated radiation, not one single radiation. So I'm trying to tell you, like, there is no right answer for this, but it's kind of like you have to think about it and the local control rate for each prescription. But I would say fractionate. This is the best. If you are not sure about the toxicity profile, because brainstem toxicity is not really something you have to worry about it. So just do 30 gray in 5. And if you're prescribing 30 gray in 5 in brainstem, you would approve the 0.035 cc to be less than 28 gray. 28 gray to 30 gray, 28 to 30 gray, depends on the volume. And you have to meet the B12 less than density and all the stuff we were talking about. So it's kind of challenging when you're dealing with a brainstem method. Now here is another case. I would be very quick now because it's 9:10. So this is a case of 74-year-old male patient having a newly diagnosed squamous cell lung cancer, okay, and has a 15 brain metastasis lesion. So you cannot imagine how tough this case when I met with him. So he is a very old guy, 74. His baseline cognitive function is really poor. His KBS is 80, and he has 15 metastatic lesions in the brain that we cannot do focused radiation, right? So the short answer for that patient is what? Is doing whole brain. But what you're bringing for him doing whole brain? It's just like you're buying him more toxicity. Besides, his cognitive baseline is really poor. You give him more memory decline, fatigue, hearing loss, and gait imbalance, right? Because with the two opposed lateral beams with the holy brains, you would affect the balance. So there will be a gait imbalance and hearing loss for sure. Okay, it's not like for sure, but I mean it's one of the high probability toxicity profiles from whole brain. So actually, in those situations, you should contact the medical oncologist and try to discuss with him. So this patient having squamous cell lung cancer, which is really unlikely to have a very potent systemic options to work on the brain for the squamous specifically. But let's say you're dealing with adenocarcinoma with EGFR positive and they have exon 19. So those patients are really highly having a very high response rate to osimertinib, which is Tagrisso. And you should start your patient on that, avoid doing any brain radiation. And you cannot imagine, like I met many scenarios that the patients have really a beautiful brain metastasis response on that targeted therapy, okay? And also if the patient is not eligible for this medication because he doesn't have this exon 19, so if it's exon 20 or 21, he will not be eligible to that. So another options will be carboplatin, Pimetrix, Pembro, and they have a very beautiful response also. ALK inhibitors would work also in the lung tumor. So here the bottom line is just try to have your medical oncologist on board, start with systemic treatment first. Because the holy brain radiation, which is the only option in your hand for this patient, I would prefer not to do it. Not to do it rather than doing it, okay? Especially if your patient is asymptomatic and you have a window interval to try systemic options on board first, okay? The other case is a 53-year-old female patient with a history of stage 4 breast cancer. And she had two new brain metastases. She had left Berman 1 and right frontal brain. Why I did this case? Actually, first for the left Berman lesion, as you can see, this Berman lesion is beside the brain stem. So when we prescribe 20 gray in 1 for that lesion, the physicist cannot meet the brain stem metrics of 0.035 cc less than 12 gray. So it was higher. So in that situation, because we can see some space between the brainstem and the lesion, we recommend the physicist just to push it high up to 12.5 gray. I would not say do that usually, because if it's a brainstem lesion, don't do that ever. But because it's beside the brainstem and you have some space between the brainstem for those fall off, so you can push it a little bit higher, and you are just dealing with a little portion of the brainstem, which is the anterior part, but not with the whole thing is at risk. You know what I mean? But if you feel like your setup error you're not sure of your setup error or your PPB immobilization of the patient, and you're not sure for the actual brainstem dose of that day, go ahead and fractionate the dose. Do 30 gray in 5 is safer, or do 18 gray, okay? So the other lesion was in the right frontal, and you can see it's barely seen lesion inside the blue circle. And why I'm discussing this case is because we cannot treat this case with one single isocenter for 2 lesions. First, because of the brainstem matrix is really hard to achieve with one isocenter in the middle between the two lesions. And the second one is because the right frontal lesion was very tiny and small that we cannot have the alignment with the one isocenter shared with the other lesion. So the best result was to have one isocenter in this lesion separated from that lesion. So that was treated as 2 different plans, 2 different isocenters the same day. What is the worst part of this is because we will have longer time of treatment that day, because you have to prove your complacency twice, you will have 2 isocenters, you will treat 2 different isocenters, okay? So that's kind of like a slide to show how you were treating with 1 isocenter versus 2 isocenter. So that's a 1 isocenter treatment. So you can see with 1 isocenter, you cannot have this really sharp dose fall off between the lesions. The lower dose will be more scattered between the lesions, which is fine. I mean, it's fine to have lower dose, and it's really more convenient to treat with 1 isocenter because of shorter time of duration. But when you have 2 separate isocenters, meaning each isocenter in the middle of the lesion that you're treating, you will have longer duration treatment, okay, but you will have better and nicely dose fall off. You will have lower dose sparing the normal brain tissue. So when you will need to do 2 isocenters. The first scenario is, as I said, if the lesions are off axis, so you cannot beam on with the same isocenter like the case we discussed. If they are 2 apart, 10 centimeters apart, so you cannot have 1 isocenter for those lesions. If you cannot meet the D12 consideration for each lesion, so you have to have separate isocenters. And then if your whole brain normal tissue minus BPPs, which is the integral dose, is beyond 5 gray that we discussed earlier, then you have to treat the lesions with not single isocenter, like in 2 days. So it will be 2 different isocenters. So I wish that like the rough idea delivered to you upon this. So as we discussed before, SRS cannot follow SRS because the rate of radiation necrosis will be 50%, up to 50%. So do not do SRS after SRS, but you can do SRS after whole brain because whole brain doesn't involve or have a high risk of radiation necrosis. Now, what is the follow-up schema that we're using here? After the patient finished his radiation treatment, we're doing 6 weeks MRI and then 3 months phases, okay? It's on 6 weeks, the first, and then 3 months phases. So I'll go very quickly discussing radiation necrosis and the couple slides coming, and then I'll finish. So whenever you're doing stereotactic radiation, so never ever we don't have side effects. So the acute side effects you will discuss with your patient is nausea, vomiting, headache. It depends on the location of your lesion at the time frame of the radiation. But what you will expect in 6 months, 4 months to 6 months interval to see. Sometimes you will see some progression in your lesion that you are treating already, and you would not expect that. You would expect either shrinkage or stabilization, right? So if you are seeing the progression of that lesion, so you will be in dilemma of what's going on. Is that a true tumor progression that is not controlled by radiation or a radiation necrosis? So the definition of radiation necrosis is an enlarging in the lesion after stereotactic radiation that displayed one of the following characteristics. Even you can prove that pathologically if you send your patient for surgical resection, or it's consistent with necrosis with the dual phase PET. I shared with you a paper about dual phase PET, so it's easy. Just try to read the conclusion so you will know how to differentiate between that and that. And also it shows itself on serial MRI studies of the brain as radiation necrosis. It has the appearance of pepper and salt. It's not well enhanced. It's not uniform. It's like scattered and irregular in shape. And at the end, this radiation necrosis will keep going on and enlarging, but it will reach a plateau at some point and then shrink back again. So that's the trend how radiation necrosis behaves. But we will never guess when is this plateau coming, and most of the patients have the troubles with its increasing in size. So there are many modalities that may help to differentiate between radiation necrosis and disease progression. There is MR spectroscopy, there is the PET, amino acid PET, there is the dual phase PET that we discussed, there is many studies, MR perfusion, CT perfusion, or fluorescent tyrosine PET, but neither of these can help you to differentiate 100% what's going on. It's giving you an impression of what's going on, and sometimes this impression is wrong. So the best is to resect that and have a pathological confirmation, but you will not do that with every single patient. These are two cases that have radiation necrosis. First patient is a female breast cancer patient that have a brain metastasis in the left temporal lobe, and that lesion was treated in 20 gray in 1 here. So we treated in 20 gray in 1. So it starts to fade away, and then it starts to recur again. So at some point here, we irradiate that with re-irradiate with 30 gray in 5 because it's intact lesion, 30 gray in 5, and we fractionate that because she already have previous radiation. So that's why I'm saying do not radiate SRS after SRS. And if you want to do that in special cases, that patient refused to do surgery. That's why we have to re-irradiate. So when we decide to re-irradiate, we do fractionated 30 gray in 5 to have a gentler dose. And even with that, with the serial MRI coming back, she started to have another area of enhancement. You can see this area of enhancement is irregular in shape. It's more towards radiation necrosis, but the thing that the patient was really symptomatic, and we cannot taper off dexamethasone off her. Like if she has dexamethasone off, she will have really very serious symptoms. So what we do at this point, we send her to the surgery, and there was surgical resection, and it comes back as radiation necrosis, comes back as dead cells, okay? So that's one case scenario. The other case, okay, and there are different management approaches for radiation necrosis. So if you are seeing that on your patient and she is asymptomatic patient, you can just observe. So it's radiological changes, not coming with symptoms, so you just observe. So one of the options is to observe. If the patient starts to have symptoms, you can prescribe dexamethasone, like 2 milligram by 2, 4 milligram by 2, whatever, and to have it as a long term, like to have your patient covered with this test for a couple of weeks and then rescan. The dexamethasone would try to help you in relieving the edema around the radiation necrosis, which is really more associated with radiation necrosis, not tumor progression. So when you have edema, you have more sense that you're dealing with radiation necrosis. So if the edema revealed, it's kind of helping the patients with the symptoms to improve. And if you cannot stop that death, so even you will send the patient to surgery, you may use Avastin, which is from Lebanon study about the ABM. So Avastin, which is the bevacizumab, can help with the radiation necrosis. You can use laser interstitial thermal therapy, which is done by the surgeon, or hyperbaric oxygen, which is a very high flow, 100 O2, which can help in radiation necrosis. In some literatures, it's proved to have a benefit. There is a very quick point about Avastin. Avastin is anti-vascular endothelial growth factor. So when you give the patient the anti-VEGF and you will have serial MRIs, you will be cheated at some point because the contrast will not be taken very well from the metastatic lesion or from the area of enhancement. So you will feel like your patient is doing great, but actually you're not seeing the contrast enhanced at this area because Avastin manipulates the vascularity of the area, and then the contrast is not taken well. So as you are not seeing what's going on, okay? So that's a tricky part of putting the patient on Avastin. But those are different approaches of how to deal with radiation necrosis. So another case of radiation necrosis was a 56 male patient with non-small cell lung cancer that we treated him for 7 lesions in the brain with SRS. And then the patient had progressive disease, and one of the lesions that we sent him to surgery because he was having symptoms. So at this point, we radiate him as SRS by 1, so it started to shrink. And then with the serial MRIs, it started to be bigger and having irregular enhancement around it with significant edema. See that edema? It's a black-gray thing. So with significant edema. At that point, we put him on DEX for a couple of weeks. We rescan him, and we make sure that his symptoms is doing better, so we just keep observation at that point because the edema is there. But then he started to have symptoms. We sent him to surgery. He had a craniotomy here, and it comes back as radiation necrosis. If it comes back positive for any tumor cells or tumor progression, you would radiate the cavity, okay? So those are the data supporting of treating SRS for more than 4 brain metastases. Yamamoto trial discussed 10 brain metastasis lesions to be treated with focused radiation, but I want you to make sure or to be aware of this trial. They treat 10 metastatic lesions, but the total volume were very low. I think it's just not beyond 15 cc or something like that. So as we said before, the matter is the volume, not the number of the lesions, okay? So that's a quick slide about the targeted CNS metastasis therapy. So whenever you have melanoma patients, I don't know, do you have a melanoma patients in Pakistan? Hello? Yes? You have melanoma patients in Pakistan?
Yes, yes, but targeted treatment is very expensive, so not all of them can afford BRAF inhibitors.
Yeah, you should not start with BRAF. You should start with Nivo-Ipi, which is in this trial. So nivolumab and ipilimumab is the first treatment line, actually. It's not the targeted therapy. So you should start with Nivo-Ipi, and it have a 50% local control and a beautiful response in the brain metastasis for the melanoma patients, especially if you combine those two together, Nivo-Ipi. So melanoma patients, you should defer radiation as much as you can. If they are not responding to the immunotherapy, either you shift it to targeted therapy, which is very common.
Can I ask a question? Like in melanoma patient with brain mets, if we start Nivo and EP and the patient is symptomatic, like having the headache and cognitive impairment, like behavior changes, whether we have to decide for radiotherapy or EP and Nivo?
Yes, so usually your patients with melanoma have with multiple brain metastases, so you can go ahead and treat the symptomatic one, and if it's big enough, you can resect it even, right? Even if you have multiple, like you can deal with the symptomatic one and leave the rest for the systemic treatment to take care of. Don't expose the whole brain for radiation with focused radiation, because you will need it at some point, so just keep it whenever it's the only choice. You know what I mean? So if there is symptomatic lesion, you can start treating that lesion with radiation or surgery, but keep the rest for the systemic treatment to take care of, like Nivo-Ipi. And if the patient progresses on that, we're shifting to BRAF. But if it's expensive, you just can, like in Jordan, we don't have very much targeted therapy options, but you can just go ahead and treat. But what I'm trying to say, give the systemic treatment the chance, especially in asymptomatic patients. For breast cancer, there are some targeted therapies that work well, like TDM1, carboplatin as chemotherapy would take care of some of the brain metastases. Bertuzumab, which is anti-HER2, some of the PARP inhibitors in BRCA positive patients. You cannot imagine. I did see one of the patients on PARP inhibitors. It's really beautiful. It's just like all the brain metastasis fades out. Okay, and there is a case report on that. I can share that with you. As we discussed before, EGFR like TAGRISO inhibitors in lung cancers and in renal cancers, some TKIs may work. But if it's failed, you can just go ahead and radiate. But what I'm trying to say, just try to spare your patient. This is the summary of all the trials we went over today. And bottom line, I would say whole brain does not improve overall survival, and they affect the neurocognitive functions. So that's why we are shifting to the era of focused radiation with the systemic therapy on board, and expecting radiation necrosis as a treatment side effect, to be aware of that and how to deal with that. And thank you so much. I'm happy to receive any questions.
Yeah, I have one question. Like, if a young patient GBM post 4 years of treatment now presented with the intra-radiation field recurrence, which is almost 3 centimeters in size, is there any role for SRS in that situation? And if yes, what will be the dose?
What's the primary, sorry?
GBM, post-60-30 temozolomide, 4-year post-treatment.
So I think GBM, we can discuss that. It's a long discussion, but the short answer is whenever you have GBM, recurrent GBM, the best is to resect first, and then to try the re-irradiation regimen of doing maybe 40.45 in 15 fractions. But I mean, that's so focused radiation in GBM is not really a very valid option unless you have a very tiny nodular recurrence at the edge of the previous cavity. So you can just go ahead and do SRS. But don't do focused radiation. Like if the patient's performance status is really poor that he cannot go back and forth for longer duration and you are just palliating that with a 25 and 5, that's not a wrong choice. But I mean, GBM is different story. Yeah, no.
I have another question. If it's intraventricular ependymoma grade 2, can we treat it with SRS? If yes, then what will be the GTV to PTV margin? A brief, short answer to that. I know we are already very late.
No, I didn't get the question. Say it again, please.
Grade 2 ependymoma intraventricular where surgery is not possible. Can we treat it with SRS? If yes, what will be the GTV to PTV margin?
No focused radiation in ependymoma, short answer.
Okay, thank you.
I'm happy to do other primaries, but because focused radiation is really concentrating on brain mets. So today our talk is about brain mets only.
Okay, thank you so much.
You're welcome. I'm happy to receive any questions.